There it is. Okay, well, good. Can everybody hear me? Can they hear me?
Yes.
Thank you. Appreciate that. Okay, is it okay if I get started here, guys?
No.
I do appreciate Dr. Igono letting me use his office.
Yeah, he's using my office. He's already contaminated it. That's neither here nor there. Zach is sort of disappeared about a year ago, and no one was quite sure whether he had formally retired or not formally retired. I'm told now that he is formally retired. His first slide indicates that he's retired emeritus, which I don't even know what the hell that means.
That's why I put a smiley
face. He's
face.
gone in anyway. Case. But the division, because of the lack of timing of this, missed an opportunity to offer Zach a good send-off, and I think there are still plans that if COVID ever ceases to stop people from meeting together, or allows people to meet, if we're eventually allowed to meet together, we're going to have something more formal. But with Zach being here and some things being collected about a year ago on his behalf, I'd like to take just a second or two to present Zach with a couple of things. One he can take home, and the other he can't. The first is the standard Henry Ford Hospital picture, which you can look at, but don't ruin because it has to be framed.
Oh, okay, I'll just.
And then a book of well wishes that people put together to send him off with, which you can open and take home and do whatever else you wish with it. Zach's been associated with the pulmonary division since about 1980, trained about that time. He was one of the first fellows I had the opportunity to teach. It was almost enough to have me quit at the time, but neither here nor there. Zach has been admired for his mind. He remembers the oddest things. Though I didn't personally experience this, he could remember where in the Detroit River exactly the last bass was recovered, or he couldn't remember a lot of relevant things, but when it came to hunting or fishing, he had a trap of a mind that let nothing get by. He was, after training here, and there's some stories that I could tell about the terminus of his training and that, but I will spare him for this time. But he went to North Dakota to Bismarck, and was the first actual board certified pulmonologist to go to Bismarck. Probably the first of a lot of things. Nobody wanted to go to Bismarck, but it was great hunting surrounding that area, and Zach took to it only to find that he got ill, came down with an illness that's haunted him for 20 years, 30 years, and forced his early retirement from critical care and brought him into the field of cardiopulmonary exercise testing and pulmonary function testing, where over the past 2 decades, he's essentially written all of the work that anybody uses for interpretation and still working on interpretive packages. So he's a brilliant guy in that regard. You're going to have the benefit of and the joy of listening to him talk about cardiopulmonary exercise interpretation. You will see as his talk goes on that I'm doing you a favor. It's supposed to be a 56-minute talk, and I'm trying to shorten it for all of you as much as I possibly can, because like his written interpretations, it will go on forever otherwise. So save your questions. Zach, you've contributed enormously to the education of fellows and residents over the past 30 years. The division, I speak for Jack and myself in the years before that, is eternally grateful. Popovich probably didn't give a shit, but that's neither here nor there. But
is he still here?
No, he retired too. So Zach, take home the books. I hope you guys contributed to the picture. I'd rather he not open.
I'll give it back to you.
But we'll get it back to him framed, and hopefully we will all celebrate together when the weather turns nice. Zach, did you want to say something? Okay. Floor is yours.
Very good. Well, gee whiz, I appreciate that, Mike. Thank you very much.
You're welcome.
Well, you may see a little bit in the corner here, Dave Singh's kind of wave over here. He's actually one of our big honchos from the Fire Company, our equipment here. We've been meeting with for the last couple hours in preparation for getting new stuff here. But I do appreciate you guys inviting me and allowing me to talk to you today because, I've got like several decades of experience reading cardiopulmonary exercise testing. And, these can be pretty daunting sometimes when you start as a fellow in your, yeah, go ahead if you want to. If you start as a fellow trying to read these things. So I want to try to teach you a way to approach these systematically, to make it a lot easier when you look at it. Hopefully we'll have a little time at the end for some questions. Okay, let's see. I have to click on this big screen over here. There we go. I have no relevant disclosures here. Okay, now a lot of what I'm going to say today, I think you guys probably still have on the, by the way, getting my profile because I'm looking at Dr. Eigenmark's second screen over here. But a lot of what I'm saying today is the American College of Chest Physicians, and I was on the network for physiology and pulmonary function testing. They asked me if I could basically create a teaching video series here to help staff and fellows to interpret cardiopulmonary exercise testing. And like I said, I think it's still on the S drive here, but if not, it's really easy to find. We made it free to everyone to be able to access. If you go to the ACCP website, I'm showing you here, and you just click on networks, there's a little drop-down box here that shows the network for pulmonary function and physiology. And when you click on that and you scroll down a little bit, you'll see these two videos. They're each about 20 minutes. They're broken into two parts. And how I'm going to be talking to you today is I'll be kind of actually breaking this talk into two parts as well. Let's start off first, though, and talk about what are some of the reasons for doing cardiopulmonary exercise testing. Okay, a lot of reasons for this actually that is really good for. One is it can help you evaluate functional impairment and exercise limitations in patients. It can help you differentiate between cardiac versus pulmonary limiting etiologies. And I think I lost my mouse here. Oh, there it comes back. Okay. It's often used by the cardiologist for prognosis in congestive heart failure and monitoring therapy and rehab. It can be used in preoperative evaluations for lung resection, heart lung transplant, abdominal surgeries, and also lung volume reduction. It's very helpful in disability impairment. I always have to keep clicking the mouse buttons, or the keyboard stops working here. Okay. And of course, it's pulmonary physicians. We use it a lot in patients with COPD and interstitial lung disease. It can help us determine if therapeutic intervention is adequate. It can help us in assessing and monitoring gas exchange abnormalities like dead space abnormalities. It can help determine the magnitude of hypoxemia and guide oxygen therapy as well as responsive therapy. And it's helpful also in risk-benefit analysis of pulmonary vascular disease. And of course, we do use it a lot for evaluation of exercise-induced bronchospasm. Now, this table comes right out of the guidelines, actually, about contraindications to cardiopulmonary exercise testing. And, it looks like a long list, but really, kind of make it really simple here. Over half this list over on the left here, these are just people with acute cardiac problems ongoing. Whether it's they had a recent MI, they have angina, they have hemodynamically unstable arrhythmias, and these are kind of no-brainers, endocarditis, myocarditis. You don't want to throw somebody on a treadmill when you have something actively going on like that you need to try to kind of tune up first. We have had situations where patients have had, we've done testing on patients that had recent pulmonary emboli and thrombosis in the lower extremity. So it's up to the fellow to make sure they do look at the charts ahead of time to kind of know why you're doing the test, know the patient's history. That's very, very important before you start any tests. I mean, these tests don't magically give you the results or a diagnosis. They basically give you a type of abnormality or classification of the abnormalities, and it's up to you to figure it out. Now, back here, there's two situations, though, and I want to point out because these are often overlooked. They seem like kind of, really kind of basic things and simple things, but, sometimes we tend to lose the forest through the trees here. And what I mean by that is that, patients, they might have sarcoidosis or some kind of interstitial lung disease or other parenchymal lung disease. And the question is, well, I don't think these abnormalities are quite as bad as what the patient's complaining of. They maybe have a little obstruction on spirometry. They may have just been given like an albuterol inhaler. But, rather than do like a $1,200 test, sometimes it's really helpful to maybe give that patient a multiple dilator regimen if you think those symptoms are consistent with asthma. just to see if that may be actually what's causing those symptoms that are out of proportion to what you're seeing on the pulmonary function tests and the radiographs. And the other thing I want to point out too, I think is really important, is that every now and then we'll see patients are referred on dialysis. Well, an exercise test isn't going to help you very much in that. I mean, the patient's not going to drop dead if you do it, but you're really not going to learn very much from it. They're already acidotic as all get out. It's going to be almost impossible to determine the anaerobic threshold. They're tachypnic to begin with. So, really, it's not going to be very helpful. Patients that have chronic infections, whether it's bronchiectasis with, purulent sputum all the time or some kind of deep body chronic thing that's being treated. If a patient has a chronic infection, they're going to feel like crap, quite honestly. They're not going to perform well either. So, just that in itself can cause problems. The relative contraindications here, to me, there's really no true contraindication in this column here. I do want to point out, though, that if somebody has really high blood pressure, 200 to start with, I'm not telling you to not do the test, but, remember, when you exercise, that pressure is going to shoot up to maybe 250 or so. And you don't want anything kind of bad happening to a patient. So things that could be controlled and treated before you do the test, very, very helpful. Now, everything that happens in exercise testing, every disease state in the world, whatever happens, can be explained by the Fick equation. Okay, remember this back from medical school. Your oxygen consumption is equal to the cardiac output times the arterial oxygen content minus the mixed venous content. Now, why we can fit just about every disease into one of these three categories is, well, let's start off with the cardiac output. Well, we know that's equal to the heart rate times the stroke volume. So basically, any disease at all that affects the heart rate or stroke volume is going to lower your VO2 and decrease your exercise capacity. Okay, any disease that affects the arterial oxygen content, whether it's lung disease that causes hypoxemia, or whether, COPD or interstitial lung disease, either one, patients with anemia. This is not the ICU where you guys, tolerate hemoglobins of 9 or 10 and patients do just fine, because we know the bad things can happen with, transfusing when they really don't need it. But, a little bit of anemia can go a long way in exercise testing, especially if somebody rather acutely drops their hemoglobin normally from 14 to 12. It's going to be reflected in their performance. They're going to feel it during exertion. Shunts can drop your arterial content. Claudication, you block the blood from being able to get to the muscles to be able to oxygenate the muscles and work. Well, that's going to decrease your arterial content to the muscles. Mixed venous diseases. Okay, these are all the things that affect your ability to decrease oxygen consumption, and they can range all the way from metabolic diseases like mitochondrial myopathies to neurologic diseases. And what these do is they will actually raise your mixed venous O2. Okay, the muscles are not able to extract the oxygen, so it just bypasses the system back into the venous system. And the result, by this number going up, it makes this quantity smaller, and that'll decrease the oxygen consumption. Now, before we actually talk about, the things that can be abnormal in an exercise test, this is like X-ray conference. If you don't know what normal is, how are you going to know what abnormal is? Well, the first thing you need to understand is what limits a normal person during exercise. If you get out and you run and run and run and run, you run till you're ready to fall flat on your face and you can't go any further. A normal person reaches a cardiac limit first. And that's why the cardiologists really like to, when they do a stress test, their goal is to get you to reach your maximum predicted heart rate. That way they know you've actually reached the limit. Now, a normal person at peak exercise will usually or should have about 25 to 30% of their ventilatory reserve remaining. In other words, you reach a cardiac limit first and you still have a lot of lung reserve, even though you may not feel like that because you're breathing in response to that acidotic state that's making you feel really short of breath. A normal person does have a reserve when they quit. The one caveat to this, however, is that athletes and fit elderly people, they can exhaust that ventilatory reserve at high levels of exercise. In other words, once they reach their cardiac limit, they can just keep pushing and pushing and pushing, trying to blow off that excessive acidosis. So what's important in these patients is that if you want to see what the patient's true ventilatory reserve may have been, look at where the VO2 was when it reached its maximum, when it's predicted maximum, I should say. Okay, you may have to go back several minutes because that'll plateau near the end of exercise at VO2 if they're really kind of pushing hard and getting more acidotic. And you will find that even though it may look like they reached their ventilatory limit, 100%, if you go back a few minutes when they first reached that predicted VO2, they might actually have like 40 or 50% of the reserve still left over. and that extra loss at the end there just because they're breathing so hard because of the acidosis they're generating. Now there's the approach to reading a cardiopulmonary exercise test. What I like to tell the fellows is think of two categories of abnormalities, okay? The first category is we're going to look for pulmonary limitations. There's three of those, okay? One, we're going to talk about each of these individually. There's a ventilatory mechanical limitation. There is an abnormality of dead space that causes shortness of breath, and there's diffusion or hypoxic limitations. And then after we look for those three pulmonary limitations, we look for the non-pulmonary causes, okay? And notice what I listed at there's three categories here, and all three of these categories are just like we looked at in the Fick equation, okay? They could be cardiac pump as non-pulmonary limitations, decrease in cardiac output. You could have the O2 delivery problems like anemia or claudication. And you can have the decreases in oxygen consumption, like the neurologic or myopathic diseases that raise the mixed mean SO2. So two categories with three really subcategories in each one. But let's first talk about how we determine if a patient has reached a ventilatory mechanical limitation. In other words, did this patient reach their predicted VE max? Well, there's a couple ways we can determine this. One, and what a lot of centers will do is they'll measure a patient's MVV on spirometry. Okay, you have the patient breathe in and out as rapidly as you can for 20 seconds. See how many liters they're moving, and then you multiply that by 3 for a minute, and you calculate what their predicted MVV is. Or you can do what we do here. Actually, you should probably do it both ways. You need to measure the MVV with spirometry, but we often use the FEV1 times 40. Some people use the FEV1 times 41. Some people use the FEV1 times 35. I find that the 40 is a little more, seems to give a little more reliable results. But remember, if you're going to use this equation, the FEV1 times 40 to determine what the predicted mechanical limit is, this requires the ability to increase both the tidal volume and respiratory rate. They both need to increase to really reach that number. If you have patients like myasthenia gravis, you might really be overestimating the true MVV by using the FEV1 times 40, because that patient just cannot sustain that breathing minute ventilation for over several minutes breathing hard. The converse of that is you can underestimate the MVV in patients that have severe restrictive disease or COPD with dynamic hyperinflation. Okay, in other words, they really have small tidal volumes. They're not increasing both the tidal volume and respiratory rate. They're just increasing the rate, trying to catch up. And that can really give you a falsely high FEV1 times 40 in those situations. So sometimes it is better to use the MVV rather than the FEV1 times 40. Now, as we've already said, if the if the VE max, if it's greater than 75% of predicted, that patient is now encroaching on their ventilatory reserve. Once you start getting down to 10 to 15 minutes of predicted VE max, at that point, you can say they pretty much reached their ventilatory mechanical limits. It's really important to look at the tracings too. I want to give you a couple examples here, because if those numbers, if the FEV1 times 40, the patient only appears to be at 50% of his predicted MVV, well, maybe they really have reached the ventilatory limit. And here's a couple of examples to show why. The first graph here, I'm showing you a patient here that has severe COPD with dynamic hyperinflation and air trapping. Notice in the blue tracing here, this is the tidal volume. It's increasing. In red is the respiratory rate. Well, as this patient reaches their anaerobic threshold, they're starting to get acidotic. And notice now, all of a sudden now, as they start to trap a lot of gas, the tidal volume starts to fall off. These are real patient examples, by the way. The tidal volume is dramatically falling off. As the respiratory rate goes faster and faster and faster, the tidal volume gets smaller and smaller. Okay, this is pretty classic dynamic hyperinflation. You see this, that patient has reached their mechanical limits no matter what your numbers show. Second example here is just the opposite, severe restrictive patient. Okay, in this patient here, the tidal volume in blue remains totally flat. He just can't get it up at all. But the respiratory rate is like skyrocketing. And notice here, this is like the number 40 over here. This patient's like up around 55 or 60 without any change in tidal volume. So when you see situations like this, once a patient reaches a respiratory rate in their mid to upper 50s, at that point, that's really about the most a person can sustain. You can say that patient has a ventilatory mechanical limitation and they're starting to poop out on you. Let's go to the second category now and talk about gas exchange abnormalities. The VE to VCO2 ratio. This is one of my favorite numbers. Okay, this term VE to VCO2, we call that the ventilatory equivalence for CO2. Some people use the term ventilatory efficiency, like Hansen and those guys. And actually, I like that term myself. That really is a measure of ventilatory efficiency. Now, to see why this ratio is useful, we have to look at the relationship of the VE to VCO2 to dead space. Now, this is the equation for what minute ventilation is dependent upon. You can find this in any physiology textbook. Actually, my favorite's like West's little paperback, small paperback of respiratory physiology. And he takes a couple pages in that book and kind of goes through the details how to actually calculate or how you derive this equation. And I don't want to go through that here. We don't have enough time. But if you're interested, you can find it there. But for right now, take my word is to say how minute ventilation here is related to the VCO2 and the VDVT. In other words, these two numbers, the ventilatory efficiency, are in this equation along with the VDVT. So we do a little bit of algebra here. We solve to get the VD, the VT on the other side of the equation. We can now see how the ratio of dead space to tidal volume is proportional now to 1 minus the inverse of this, the VCO2 over the VE. So in other words, as the minute ventilation increases dramatically, which is actually decreasing this year, being the inverse of it. So as this ratio is decreasing rapidly because of the rise of minute ventilation, because we're subtracting it from 1, this quantity is getting smaller, 1 minus this diminishing ratio. So it means that the dead space ventilation is going to be increasing, dead space and tidal volume. Now, keep in mind during exercise, patient's dead space doesn't really change at all. It stays pretty constant. What changes is the tidal volume. A normal patient will progressively increase their tidal volume during exercise, dropping the ratio while the VDT stays pretty constant. But you can see how the VCO2 to VE, or should say increasing VE to VCO2, a rising value will indicate worsening dead space ventilation. However, the caveat to this is hyperventilation can also increase this ratio. So I'm going to show you the exact same equation again. What we ignored in the last slide was this value, the PaCO2. Now, normally in a normal person, dead space stays the same as you increase minute ventilation because you're dropping your PaCO2. As the minute ventilation goes up, the arterial CO2 goes down the exact same proportion, and it keeps the VDVT the same. Okay, so sometimes you need to do serial arterial blood gas throughout exercise to help you distinguish increasing dead space abnormalities from actually hyperventilation. Now, when we measure VE to VCO2, we measure that at the anaerobic threshold. The reason we measure at anaerobic threshold is it's a consistent point that in any given patient, that point that's going to be fairly consistent when they hit that point. If you measure it too early in exercise, you got a problem because remember now, when you first start out on the bike there, you're scared, you're uncomfortable, you're nervous, you're hyperventilating. That number, the VE to VCO2 is going to be bouncing all over the place. If you measure a peak exercise, well, that's a problem too because peak exercise, some people quit as soon as they hit AT, or they might go all the way to the peak exercise, about 30 to 40% past AT, and that number keeps going up and up and up. So AT is kind of a good point to measure that because that's when a patient is now breathing more in response to their metabolic demands rather than because their discomfort or their anxiety. Now we measure the VE-VCO2 in different ways. There's 3 ways this term is used, and I think it's important to differentiate these different ways. The way we use, and I feel is the most accurate, is we look at the actual ratio, the spot value of the VE to VCO2 at anaerobic threshold. I want to show you over here, these are 2 normal patients. I think this actually came out of one of the Hansen's articles. They're 2 normal patients here. And first, let me describe what we're seeing on the graph here. We look at the VE to VCO2. Normally in exercise, that'll progressive decline. In other words, your minute ventilation is rising a little more rapidly than your CO2 production. But when you reach anaerobic threshold, you start producing lactic acid, this curve will go flat. Okay, notice it goes flat. The beginning looks different in each one, but it goes flat in each one. And before it starts to go up again. Now, the reason it's going flat is we call that point isocapnic ventilation. And when you start becoming acidotic, the lungs do have the ability to be able to buffer a little bit. They have some buffering capability, not as good as the kidneys, but we can't wait 3 days for the kidneys to catch up. So what will happen is the lungs will buffer. But once you get beyond the lungs' ability to buffer, the acidosis progresses, the metabolic acidosis or the lactic acidosis, and then the ventilation steps up. We call this point the ventilatory compensation point, VCP. Okay. And when they hit that VCP, that's when the tracer will start to rapidly rise again at the end of isocapnic ventilation. Now, notice how by using this ratio in each of these patients here, the numbers are almost identical. If we look at AT, it's 29.2, and here it's 29.7. Okay, well, the second way that some people will use is they will take the lowest VE to VCO2. And here we see the numbers are pretty close, 29.1. And here it's 29.7. It's exactly the same as the looking at the spot value. Now, this method works pretty well if you're looking at a normal person. But unfortunately, when people have chronic lung diseases or other metabolic disorders, this tracing, that may not go flat on you at that compensation point. It may progressively go down, but change slope a little bit. So, people that use this usually don't feel too comfortable at using the number one method here on that one, but it can be used. The third thing I got to really make the strongest point about, though, is the method that is often used is called the VE to VCO2 slope. This is the one that when you see the cardiology reports here, when they do exercise testing, they often report this slope. Okay, now notice on this graph here, we're not looking at the ratio, we're looking at actually the minute ventilation on the y-axis to the CO2 production on the x-axis down here. And what you do is you take a line, you find a slope from the start of exercise on here, the VE to VCO2 ratio, and you draw a line through the slope all the way up to the ventilatory compensation point, which is usually about a third of the way up past AT. But you go up to that point here, okay? And you measure the slope of that. And as I said, it's used by cardiologists in congestive heart failure very often. But notice in these two patients up here, they had the exact same, pretty much same VE to VCO2 at AT. But notice now down here, the slope is 21.8 over here and 30 over here. Look at that, it's like 30% difference between the two. Well, the reason for that is because this patient here, it's blunted, it's a lot flatter because he's not going through the 0 point like this patient is here. Okay, they're starting in a much higher minute ventilation, which in cardiac patients, that's kind of okay because they're in chronic congestive heart failure. They are going to be more short of breath, even at rest, more tachypnic, higher respiratory rates, a little bit of pulmonary congestion in there. So that's going to drive the slope up. I'm sorry, it's going to drive the intercept up to make the slope significantly lower. Now, if you look at a lot of tests, even in fairly normal people, the intercept goes through 0 only at about 5% of the patients. 95% of the patients you look at, it's going to be blunted, and it's going to be up. I lost my arrow again. It's going to be blunted, the slope, compared to when it goes to the 0 axis, even though they may have the exact same VE to VCO2 up here. Now, I want to mention, and I'm not saying this is a lousy number. I'm saying that this number you have to take in the proper context. This is a number that's used in patients with congestive heart failure. That's what the literature shows. I guess I look at this as kind of, when you try to use this of every disease in the world, it's kind of like equivalent to what a lot of people in pulmonary do with the gold statement. In other words, the gold statement is a wonderful tool for assessing and managing patients with COPD, but that's what it's meant for. That fixed ratio, if you're less than 70%, if you go into FBC, they say by definition you have COPD. Well, we know that's nonsense in most people because 30% of the normal population is below, when they're still within the confidence of the normal, they are still below 70%. Okay, so, you can't use gold to interpret every disease in the world, which some people try to do that. It's meant for COPD assessment. Well, the same thing happens in with the V-slope method here. A lot of people you try to use that to interpret every disease in the world, and it just doesn't fit. So let's talk about what an abnormal VE to VCO2 is at AT. The fixed value is often used of greater than 34 as abnormal. Okay, but the problem with this now, this varies with age. Young adults, their upper limit of normal is 31 if you're males, like if you're 30s. If you're females, it's 32. The upper limit of normal does not reach 35 or above that 34 until you're at least the age of 80. It increases linearly with age. Females are always like 1.0 higher than males. Well, again, getting back to the cardiologist or V-slope method, they say anybody has a value greater than 35 at peak exercise can face the worst prognosis in patients of all. But hey, we know that normal people at peak exercise, when they're above anaerobic threshold, which most people can achieve, normal can be up to a value of 40. So again, you have to kind of interpret that in the proper context and use it for what it's meant for when using the V-slope method. And like I said, it is a very good tool for managing congestive heart failure and determining prognosis, just not for using it in somebody who's a young athlete. Okay, now the problem with using the VE to VCO2 though, it's abnormal in just about everything. That's a non-specific abnormality. When patient has an elevation that does explain why they're short of breath, you got a good explanation for it now, but then it's up to you to figure out the cause. Is it pulmonary, cardiac, vascular, metabolic? Everything can do that, and even hyperventilation. Now here's the really kind of weird thing. You might have an abnormal VD-VT, but your VE-VCO2 ratio is normal. And that's because if this number is high, with dead space ventilation, if you have another underlying disease that causes like hypoventilation or metabolic alkalosis or chronic respiratory acidosis, making your end tidal CO2s even higher, well, it's going to start dropping the ratio in the other direction. So it might have been abnormal, but then you add this other metabolic or hypoventilation problem, it's going to start decreasing the ratio the other direction, and it cancels it out. Let's talk about the third type of abnormality, and that's diffusion abnormalities. What we're talking about diffusion here, we're actually talking about not the PFT definition, but actually the ability of oxygen to passively exchange across the lung surface. And that's an easy one to measure. We do that by oximetry. Preferably ear or forehead over the finger, because if you have a finger probe and a patient's squeezing a bike and he's getting near the end of exercise and he's starting to grip hard, well, that number's going to be bouncing all over the place and look like he's really profoundly hypoxic when he really isn't. Okay, we call a decrease in saturation of greater than or equal to 4% significant. Okay, now it's not unusual in fit elderly subjects, they can actually drop more than 4% if they're in pretty good shape, but it should not fall below 90% in the hypoxic range. Some people then say, well, geez, oximeter today's they're really accurate to 3%. And that's true, they are. But remember now, we're trying to measure this oximetry in a patient on a bike who's bouncing all over the place. So there's going to be a lot more artifacts. So we kind of widen the margin a little bit just to be sure what you're looking at there. Now, keep in mind that if someone does have a reduced anaerobic threshold, and their oxygen saturation is greater than 90% at that point, well, the diffusion is not the cause for the reduced anaerobic threshold because they're still oxygenated. So basically, just to end the pulmonary limitations we're talking about now, we talked about three types: the ventilatory mechanical, how we measure by either an MVV or an FEV1 times 40, and they should be less than 75% predicted. We talked about the abnormal gas exchange or abnormalities in dead space ventilation. Sometimes you may need a arterial CO2 to evaluate for hyperventilation and metabolic causes. The predicted values, you want, if somebody's above the age, above 34, no matter what their age, you can always say they're abnormal. Okay, but also keep in mind that patients that are normal, they can have a value up to 40, the size 40, a peak exercise well above 18 and still be considered normal. And then we also talked about the diffusion or hypoxic abnormalities we measure by drops in O2 saturation. So the three pulmonary types of limitations are actually, they're pretty straightforward. And as lung doctors, when we do tests, I say always look for these types first. Go here first and then go to the other stuff. So let's now talk about the non-pulmonary causes. This is going to be the second video on that ACCP site. First, we need to understand what anaerobic threshold is and how to identify it. Okay, the anaerobic threshold is the exercise VO2 above which there is a supply-demand imbalance of oxygen in the muscles. In other words, there's a net increase in the lactate to pyruvate ratio. We know that this excess lactate from the hydrogen ion binds with bicarb, combines to carbonic acid, and then because of the carbonic anhydrase that's located inside red blood cells, it will dissociate the water and CO2, which then the body eliminates by increased ventilation. Pretty sure we all know that. Okay, now before we get into other things, there's a really important concept you need to understand here. This is often missed by people that read these tests. Oxygen consumption and work are always linear, okay? Even when you reach, like this patient here, the blue line here, this is the normal patient, even when they reach anaerobic threshold, a lot of people have this assumption that, boy, once you reach AT, your oxygen consumption decreases. No, that's not the case. It still increases linear. It's just what happens is your body is just, the muscle demand is greater than what you can supply, but you're still supplying on there. It still goes up linearly. What happens in patients like with congestive heart failure, the curve becomes flatter. But again, AT is going to be much lower in heart failure, much lower VO2 here, but it's still going to increase linearly. Well, how do we identify it on the graphs? Well, what I like to do is I like to superimpose four graphs that distinctly change their shape at AT. There's a number of ones you can choose, but these are kind of four of my favorites here. Now, I should add that if you read textbooks, guys like Wasserman and Jones and the other guys, they'll show you this page of like 9 little postage stamp graphs on a little page there where they mark AT. And I got to tell you, I have an awful time trying to find it on those little things. I don't think there's enough there. I like to kind of make a big graph, and I like to put 4 different tracings on there. And what we have here, we'll go through them one by one. First, we have what we call the ventilatory equivalents for oxygen, the VE to VCO2. The definition of AT on this blue dots here, it goes down and down and down, but when it hits its lowest point, before it starts to go up, we call that AT. If there ever is a gold standard, or maybe a silver bronze rather, this should be the one for that. The second tracing, I like to look at the ventilatory equivalents for CO2. Remember we talked about this already a few slides ago? Okay, well, this patient's in red. You see here it goes down. When the patient hits the anaerobic threshold, he goes through that buffering stage of isocaptic ventilation. And then once again, the lungs kind of lose their ability to compensate anymore as the acidosis gets worse, and then this goes north. The third number I like to look at is what we call the respiratory quotient. Okay, literally that is the VCO2 over the VO2. Now, I'm going to kind of pause here a second just to remember how the slide before I said how oxygen consumption is linear. That stays linear throughout exercise. Okay, so in other words, anything that makes the shape of these graphs change, because we're looking at ratios, it's because of either the minute ventilation making a change or the CO2 making a change that make it go into this U or V shape. So with the respiratory quotient here, now that we're looking at the VCO2, that might go down in the beginning, might stay flat, everybody's different. But when you get to anaerobic threshold and you start stepping up your CO2 production faster than the oxygen consumption, this graph will start to take off and go north also. And then the last tracing I like to look at is what we call the end-tidal PCO2. Okay, now this is one that's used kind of hard to determine their AT, but I like to throw this in there for the fellows' benefit so you understand the physiology and exercise. There's other graphs I could have put on there that were easier to read and probably sharper to read, but I think it's important to identify this concept physiologically. Okay, this end-tidal O2 will step up when you reach anaerobic threshold. Now the question is, can I usually ask what more fellows? Well, when you reach AT, what's going to happen to the end-tidal O2? Is it going to go down and go up? Is it going to stay the same? It's kind of the typical response. Most patients right off the bat will say, oh, it's going to go down. Well, it's just the opposite. It goes up. The reason for this, now follow through on this. If you kind of get lost here, you can always go to the video in the section here. And when you get to this one slide here, hit the pause button and kind of go through a little bit slowly, just step by step every few seconds. But essentially what's happening here is as the pH decreases, you're getting more acidotic as you get to anaerobic threshold. It makes your minute ventilation start to increase. Okay. Now, as your minute ventilation is increasing, that's going to make your alveolar CO2 start to drop. In other words, you start to blow it off a lot faster here because you're getting more acidotic now. So you're starting to blow off that excessive CO2. And you're causing basically an alveolar hypocarbia. Okay. Now, you always want to, because your mouth is open, an open conduit all the way down to the alveoli, in order to maintain 1 atmosphere of pressure between the mouth and the alveoli, as the PaCO2 is decreasing, remember we established that, you're blowing it off faster now, so the PaCO2 is decreasing. That makes the alveolar O2 rise. Okay, well, the reason it's rising is you have 20% nitrogen in the alveoli, 80% nitrogen in the alveoli, 80% nitrogen in the air. That nitrogen's not absorbed, so it's the only 2 gases we're dealing with are CO2 and O2. Well, as you blow off the CO2 in the alveoli to maintain 1 atmosphere of pressure, something's got to take its place. And so that means the alveolar O2 is going to start rising. Because remember, out at the mouth, it's about 150 millimeters. And by the time you get down to the alveoli, it's around 90 or 100. Well, you blow off the CO2, the alveolar O2 has to increase. And so you're blowing that off. You see a rise in the end-tidal O2. And as I said, hopefully I didn't lose you on that, but it's easy if you look at that video to kind of make it make sense. Okay, so you pick a line that goes through all of these points. And if you have a line that seems to match all of these, you now got a slam dunk. You just found your anaerobic threshold correctly. Let's look at a real patient now. Okay, this is actually a real patient on the graphs here. So what we do is, remember the definition of the ventilatory equivalents for oxygen is the lowest point before it starts to go up. Okay, kind of goes flat here for a while ways, but the lowest point is sometime right about in here. Okay, we look at the ventilatory efficiency. Where does it hit isocaptic ventilation in red? Well, here we see it starts to just go flat here, around this point here, goes flat. We look at the respiratory quotient here. This one's kind of easy because we see a significant step up in the value here. And then we look at the end tidal O2, and we see again, there's like a step up that occurs here. So we draw a line, and if we draw a line that goes through all four of those points, again, you got yourself a slam dunk on finding it. A lot of people will recommend using the V-slope method. This is what a lot of the textbooks will tell you. This one really drives me nuts because I think this is really hard to read. I think I got this out of Wasserman. It might have been Jones, but I think it was Wasserman, one of his graphs. They use what's called the V-slope method. What you do is you look at the amount of ventilation on the y-axis, and then you look at the VO2 on the x-axis, and you look at the point where the slope changes, goes up, and you call that AT. Well, notice on this guy here, I don't see anything. It's really easy if somebody puts a dotted line on there for you, like Wasserman did here. But quite honestly, look at these three dots. I don't see the line going through any of these. If I had to draw this, I probably would have done this. Okay, I would have said, hey, look, I found a line that goes through all four of these, and then one that goes through all three of these, where it really didn't done any of the ones. I think the only point it really touches maybe here and here. But if you go through points, I wouldn't. But the problem is this. Let's look at this. This is 1.6 liters versus down here at 1.2. I mean, that's like a 30%, 40% difference. So to me, I think this is just not very accurate. Sometimes you'll find an occasional test where this is the most accurate method, but definitely make sure the match is on all of them. Then the question comes up, well, remember now, when you see these graphs in textbooks, they usually measure, they average like every minute your gas collections. That's why there's so few points here. This makes it really difficult because when we do our tests here, I like to do every 20 seconds. Some people do every 30. Some people do by an eight breath analysis. So you get a lot more data points. It's easier to draw a graph doing that. And that's why there's so few data points here. So could this actually be the ventilatory compensation point up here? What I'm doing, at the end of isocaptic ventilation, who the heck knows? Don't know. Okay. So now I have to determine, is the anaerobic threshold reduced? Well, how to report anaerobic threshold? Well, that's reported as the VO2, the oxygen consumption at AT, divided by the predicted maximum VO2 times 100 to make a percentage. In other words, what's the VO2 at AT divided by the predicted maximum VO2 expressed as a percent? Now, remember, predicted VO2 varies depending on the population studied and their degree of fitness. Now, you have to really use predictive values for your area. I don't think it's really a smart move to take a set of predictive values. Let's say somebody lives in Bulgaria, eastern side, where they have to walk 5 miles to work or pedal a bike 5 miles to work and then ride a bicycle home up a mountain 5 miles. They're obviously going to be a lot better shape than any of us are. So you have to pick a predicted population that fits where you are. Now, we do know that an anaerobic threshold, anytime it's less than 40% of predicted VO2 max, it's always going to be abnormal. Okay. However, we know that patients, once they reach the age of 25 or 30 years of age, that starts increasing. It goes up by about 2% every decade, or by 1% every 5 years. So by the time you're 75 to 80 years of age, the lower limit of normal is actually 50% of predicted the VO2 max. The reason this goes up like this is because AT and VO2 max, they both decrease with age. But the predicted VO2 max decreases more rapidly than the anaerobic threshold does, so it makes that ratio start to rise. Now, I created our report, so I've actually got the equations on the report, so that will actually give you a more accurate AT rather than just saying 40%. Not sure if we can do this on a new equipment we have coming in. We're going to have to figure out how to do that, but you do have to adjust for age on that one. Now, once you determine if you have an anaerobic threshold, I'm not going to spend a lot of time on this cartoon here, but we all know that cardiac causes can reduce the anaerobic threshold. But there's so many other things you can do it to, and you really have to go through the list in your mind. So how I like to recommend to people to do this is pretend you're a little red blood cell. Throw yourself into the left ventricle and follow through the higher circulation till you come back to the lungs again, or the heart. And then think about all the things in between, like could there be anemia or ischemic problems in the vasculature? Could you have some kind of metabolic or neurologic disorder? Even bad venous impairment, compression thrombotic disease can impair the metabolism of the muscles, causing congestion and decrease AT. I throw end organ disease in here because remember, people with chronic kidney disease and hepatic disease have all these metabolic toxins running around in their system. It's going to affect muscle metabolism, and that in itself can decrease your AT. You guys all know about the pulmonary vascular diseases and the right ventricular dysfunctions, dysfunction that can cause impairment of cardiac output and hypoxemia. You get back into the lungs again, you have all the diseases that cause hypoxemia, ILDs, and the COPD. And then don't forget about this little piece of the circulation between the lungs and the heart, the pulmonary venous circulation. I've been looking for one for 40 years and never found one, but it has been reported this could actually be a sensitive test for people with pulmonary veno-occlusive disease of showing abnormalities that really aren't showing up anyplace else. Okay, well, what are some numbers we can look at to measure on the non-cardiac causes? Well, I like the O2 pulse. That's a neat number. What is the O2 pulse? Well, the O2 pulse is the oxygen consumption divided by the heart rate, and that's proportional to the stroke volume. And why that is here comes the Fick equation again. Love this equation. Okay, the Fick equation, what we're going to do here is we know the cardiac output is equal to the stroke volume times the heart rate. And we also know that during exercise in any given patient, the arterial oxygen and mixed venous content is going to be relatively constant throughout exercise. So we can kind of toss him out of the equation now. We can say now that the oxygen consumption is proportional to the stroke volume times the heart rate. We do a little algebra here, cancel out, divide by heart rate, cancel out here. And lo and behold, we now have the VO2 divided by the heart rate is proportional to the stroke volume or the O2 pulse. Now, let's look at some of these tracings here to show you how these can really be helpful. This patient here, this is the norm. Okay, this is a patient in blue is the O2 pulse. You can see a stroke volume progressively increasing, heart rate is going up. And when a patient reaches their normal or their predicted VO2 max and heart rate, if you see a little plateauing at the end of this now, that's good because that means that patient gave a maximal effort. His stroke volume is starting to plateau now. He's reached his limits. Here's a patient with pump failure, cardiac disease. Now here's a patient here, the O2 pulse, it's a lot lower. Notice this here, it's blunted. His VO2, he cannot achieve a normal VO2 because his stroke volume goes flat. His heart rate keeps trying to go up, but it's not enough to compensate to get to that predicted VO2. Okay, and here's one of our severe pulmonary artery hypertension patients. Not unusual to see this. We see quite a few of these. This is a patient where we actually see pump failure. The stroke volume is going up as soon as this patient gets to anaerobic threshold. You notice here, can you see that okay, by the way? Okay. As you reach anaerobic threshold, he's plateauing, but now the stroke volume is starting to fail. It's actually going down. Notice how the heart rate now, trying to compensate, is starting to really take a change in slope and start to skyrocket here. Okay, that's a patient, that's a really very sick patient. You can actually see the pump failing on these graphs. Okay, now and remember though, for O2 pulse to reflect stroke volume, it is assuming the arterial content mixed venous are constant. They're doing what they're supposed to be and relatively normal. Okay, they can also decrease the O2 pulse. So in actuality, we can say the O2 pulse is equal to the stroke volume times this quantity, but you got to make sure this quantity is not the cause of the disease or reducing the oxygen consumption. Some of the other numbers we can measure here, we can look at the heart rate divided by the oxygen consumption. We use that heart rate response different than the cardiologists do. What we're doing here is we're actually looking at the change in heart rate between rest to peak exercise and dividing it by the change in oxygen consumption from rest to peak. Any value above 50 is usually considered abnormal. It kind of makes sense when you think about it because the patient's getting excessively tachycardic for the amount of oxygen being produced, which could occur in pump diseases or myopathies. Now notice also, this is actually the inverse of the O2 pulse. We flipped them around. But the difference is the O2 pulse, we're measuring a spot value, and this we're actually measuring the slope of these values. And it has all the same causes of reduced O2 pulse. Keep in mind, though, it sometimes can be increased in deconditioned patients if they quit early. Early in exercise, they can be really excessively tachycardic for a low cardiac output, but if they usually can still achieve their peak VO2. So you have to make sure that patient is giving a good effort to get to their maximum values if they're normal and just deconditioned to separate out these two. Another method I like to look at is the slope of the oxygen consumption to work. Now, if you go to the graph of the VO2 on the y-axis in the work, you can just take your mouse in our equipment right now and just drag it across that line. It'll create a slope for you and calculate it. The lower limit of normal in males as well as females is 8.5. That's pretty much pathognomonic we found for heart failure. Of course, you need to exclude other things like anemia and metabolic or neuromuscular diseases. But it's a pretty good number, good confidence interval. Keep in mind also that if a patient achieves a normal predicted VO2 in a normal anaerobic threshold, but they do it at a very low workload. Let's say instead of like one of you guys that hits your AT at 80 watts, well, if you hit that same AT at 20 watts, you're still normal. You're just really deconditioned. Okay. Obesity can do the same thing. The reason obesity does that is, remember, we're measuring watts on a bicycle. If you weigh 350 pounds and half your body weight's in your legs, well, when you're pedaling that bike, the bike is not measuring the wattage from that extra mass on your legs, that obesity. So that's going to lower actually your VO2, your oxygen consumption per work rate, because you're not measuring all the work based on your body weight. The last number we're going to talk about is the VO2 per kilogram. Now, this is kind of a controversial, because the literature, I think you really should correct for ideal body weight. A lot of the literature doesn't. And it kind of makes sense, though, if you have a 150 kilo or 80 kilogram guy versus a 150 kilogram guy, this number is going to be half what it was, because fat really doesn't have a lot of oxygen metabolism. It does have a little bit, but not enough to make up for that difference. This number is used prognostically for assessing pulmonary surgical risk factors, pulmonary rehabilitation planning. It's used in cardiac failure and transplant evaluations. But you do need to keep in mind, if a patient is on beta blocker therapy or had resynchronization therapy, it kind of loses its value at that point. Well, let's talk about how we use this as pulmonologists. There's entire articles. You can give like a whole lecture on this alone. So I'm going to try to summarize this in just a few minutes for you. When should you do an exercise testing to look at this value? Well, if you're considering pulmonary resection and you have a postoperative predicted value of your FEV1 less than 80% of predicted, or FEV1 less than 1.5 liters following a lobectomy, or less than 2 liters of pneumonectomy, that's when you start thinking about an exercise test. Now, if your predicted post-op FEV1 is less than 30%, you've got a pretty high risk category. Some people will take the percent predicted post-op FEV1 and percent predicted post-op diffusion, multiply them together, and if you have a value less than 1,650, now you don't see this very often. That really is a pretty good number to keep in mind, because that can give you a pretty good prognostic indicator using both FEV1 and diffusion to say you're probably wasting your time even going to an exercise test. If they're over here on the right side, if their percent predicted FEV1 and diffusion are greater than 40, that puts them in a pretty low risk category. But what about all the people in between? If you have that predicted post-op FEV1 and diffusion less than 40%, that's when the exercise test can help you. If you have a VO2 per kilogram that's less than 10, that patient's got a pretty poor prognosis. On the other hand, if you're all greater than 15 per ideal body weight, that's milliliters per minute per kilogram, you're in a very low risk category. Unfortunately, a lot of the patients fall in between here, and the VO2 per kilogram between the 10 to 15. Now, this is where you really got to know what you're doing here, because what's the best VO2 achieved? If you did not have a limiting factor in that exercise test, or ventilatory mechanical limitation or a cardiac limitation with a number in here, you could be, writing this patient off prematurely and making him have a worse prognosis than he really has. When I see that situation occurring, when I would retest, I would actually have we'd bring the patient back again. We'd spend a lot more time ahead of time explaining to the patient, what we really are looking for, how we really have to get a little more effort, because he quit too early. We knew he was not anywhere near his predicted values when he stopped. And very often when you explain all that, how this can mean the difference between life-saving surgery or not, that now they know what to expect. They've done the test before. They can actually do a lot better the next time. And if they have a 13 or 14 to begin with, and this between the 10 and 15, you can often push them over that 15 and make things a lot better and make the surgeon feel a lot better. Well, how's this number used in congestive heart failure? Remember again, I'm emphasizing chronic congestive heart failure, not all cardiac diseases. They say if you have, again, same number as us, if the VO2 per kilogram is less than 10, you're in a real high risk category. The other end, they say instead of 15, they say if you're above 18, you're pretty low risk. Now, what they do to help discern the quality of tests is these low category, they look at the respiratory quotient. Remember the respiratory quotient, that's the VCO2 over the VO2. So it kind of makes sense. The higher that number is, the higher CO2 means the more acidotic you got. It means you gave a better effort. If you have an RQ that's less than 1.15 at that peak exercise, well, maybe you kind of quit kind of early, and they stratify those patients at a little higher, a better risk category. They look at that VE to VCO2 slope at 34. Remember, you got to be cautious how you use this. And they say if it's greater than 34, that patient has a terribly bad prognosis at peak exercise. and I say, keep that term, remember that, peak exercise, because in patients that are normal, a peak exercise can be up to 40. So in congestive heart failure patients, because of that V-slope method, because it's not going through the zero axis, it'll be a lot more blunted. So, but they're calling it 34. Through that point might actually be a much steeper number at that point. So, and they also say if it's less than 35 using the V-slope method, a much better prognosis, less dead space ventilation. Don't want to spend a lot of time in the cardiac aspect, but I just want to point out how, maybe we can learn something from the cardiologist here, though, that maybe we should do more studies with how we do these, looking at the RQ and the VCO2 to stratify some of these people in the in-between range. So in summary of what we talked about here, of the non-pulmonary values, we talked about AT. If it's less than 40, it's always abnormal, but you should adjust for age, and the very non-specific test when it's abnormal, just about everything can do it. You need to know the history. We talked about the O2 pulse, reflects stroke volume. Does it achieve normal? Look at the tracings, compare it to heart rate. Look at the inverse of it as far as the change of heart rate to VO2. If it's less than 50, it can indicate like a pump or a myopathic disorder. We talked about looking at the slope of the VO2 to work. That number of 8.5 is the lower confidence limit of normal for males and females, but again, exclude anemia and metabolic disorders. And lastly, we talked about the VO2 per kilogram. We just looked at how to stratify that. As I said, I certainly would look that up, articles on that, since we could give a whole lecture on that one. I just wanted to give a quick summary of it. And above all, do not forget about the EKG. In other words, are there any conduction or ischemic changes that might correlate to chest symptoms or reduce the anaerobic threshold? But in particular, look at the rhythm too, because we've had cases in the past, kind of interesting when they pop up. Did the patient go into an SVT? Kind of interesting because how heart rate is supposed to go up linearly, okay, throughout exercise. Well, if you have a patient goes up linearly and then all of a sudden it starts shooting up, look at the EKG carefully, because what looks like just a rapid heart rate due to exercise could be the patient went into an SVT at that point. So do not forget about the EKG. Really spend a lot of time with that as well. And on that note, we're going to stop in the end. And we have maybe a couple minutes if anybody wants to ask any questions. If not, whatever, I can hang around for a little bit too. And I think we're done. Thank you. Okay, I'm not sure what to do next here. Are we good? Should I hit the stop video or mute button now?
Yep.
Okay.
And I will actually just do that because that way it'll record, and then let me see, stop share.
Oh, there's a lot of people listening to this. Look at that.
Thank you for the lecture.
You're quite welcome. It was fun. Oh, there's
Thank you,
Franco.
Doc.
Hi,
And,
Franco.
and congrats on the retirement.
Oh, well, thank you.
How many
Lecture.